Hey guys, this is Dr. Hub. In case you haven't subscribed, please do subscribe. This is a concise, well-crafted summary and it highlights only the important keywords. Pheochromocytoma. So here, what is origin? Origin is it arises from the adrenal medulla, chromaffin cells. Incidence is mainly in the 4th and 5th decade in both genders, and most common site being the adrenal medulla. It can be extraadrenal as well. Characteristics are it is about 10% malignant, 10% bilateral, 10% malignant, 10% bilateral, 10% pediatric, 10% familial, as well as 10% extraadrenal. Now, what are the risk factors? The risk factors, it includes the familial association. The familial association can be sporadic or familial, syndromic and non-syndromic. It can be syndromic and the non-syndromic. Next, what are the syndromes associated? It will be MEN 2A as well as MEN 2B. Then there is von Hippel-Lindau's, VHL. The von Hippel-Lindau's syndrome is associated, as well as the von Recklinghausen syndrome, VR syndrome. So VL syndrome, VR syndrome, and the Sturge-Weber syndrome. So what is a non-syndromic familial association? It is associated with the succinyl-CoA. Succinyl. This is a succinyl-CoA. Succinyl dehydrogenase D. So non-syndromic familial association is the succinyl dehydrogenase D and also the B mutation. Now, clinical feature wise, it has the palpitations. So there are palpitations. So there is palpitations as well as a headache. Palpitation. There is headache as well as a diaphoresis. Next, what about the other manifestations? Other manifestations, it includes chest pain, anxiety, carbohydrate intolerance, carb intolerance. There is weight loss, ileus, cardiac manifestations, as tachycardia as well as the arrhythmias. Now, what are the investigations of this? Investigations is most sensitive test, the most sensitive test, and next there is a 24 hours urinary, the most sensitive test. This 24-hour urinary catecholamines and as well as the vanillyl mandelic acid, and our best for diagnosis will be the plasma free metanephrine. Now, the MRI is a radiological IOC, the investigation of choice, that includes adrenal pheochromocytoma. There is a extraadrenal pheochromocytoma as well as the pheochromocytoma in terms of the pregnancy. Now, what is the role of the MIBG? The MIBG is the meta-idobenzyl guanide scan. It is only useful for the extraadrenal pheochromocytoma. So, MIBG is for the extraadrenal pheochromocytoma. There is something known as a 18-fluorodopa, PECT and the CT. So, what is the gold standard for the staging? So, in case you're looking for the staging, the gold standard will be the FDG. So, there is FDG, PET, and also the PET scan. So, these are done for the malignancy as well as the metastasis. So, PDG and the PET scan. So, how to treat this condition? Treatment is by there is a volume regulation which can be done. So, this is by the crystalloids. So, crystalloids as well as the colloids. Then comes the BP, that is the blood pressure, alpha blockers, phenoxybenzamine. After this, the beta blockers, they should not be given until the potent is fully alpha blocked, so that to avoid the hypertensive crisis. So, while doing the beta blockers, you should be very careful. First, the alpha should be blocked so as to avoid the hypertensive crisis that might develop into the unopposed alpha stimulation. Next is nasal stuffiness and tachycardia. For this, we have to start again the beta blockers, and after adequate alpha is blocked, then adrenalectomy is done for the adrenal tumors. adrenalectomy, as well as you do a laparoscopic adrenalectomy. This is for the tumors which is less than 5 centimeters. To learn and grow daily like this, please do subscribe.